A routine urine sample is essentially a high-density data artifact, a non-invasive liquid biopsy of the entire renal system. Evaluation of this fluid requires decoding 3 distinct layers: macroscopic physical properties, cellular debris, and metabolic fallout. This data represents the first layer of diagnostic evidence, where specific macroscopic variations immediately indicate the state of the kidney. Visual inspection identifies exogenous compounds, or systemic errors of metabolism, well before a microscope is required. Desferoxamine creates a pink hue, rifampicin turns the sample orange, and a mousy odor signals the metabolic failure of phenylketonuria. Mapping these macroscopic observations to specific microscopic geometries allows us to trace pathologies to their exact anatomical origin in the kidney. When red blood cells appear in the urine, hematuria becomes a critical branching point in the diagnostic algorithm, requiring a distinction between upper and lower tract origins. Bleeding from the lower urinary tract typically presents as pink or red urine, often containing microscopic clots of clumped erythrocytes. Glomerular bleeding is characterized by a dark cola-colored presentation, the result of blood degrading during its transit through the nephron. Microscopy confirms the source. On the left, uniform, round isomorphic erythrocytes indicate lower tract bleeding. On the right, the glomerular environment yields distorted, ring-formed cells. These acanthocytes possess an irregular membrane with protrusions, a distortion resulting from passage through a damaged glomerular basement membrane. Erythrocyte morphology splits the diagnostic tree. This observation identifies medical glomerular disease, preventing unnecessary surgical workups of the lower urinary tract. Beyond free-floating cells, we analyze larger, cylindrical structures known as casts. Casts form in the distal convoluted tubule and collecting duct when TAM horsefall mucoprotein precipitates. This creates a cylindrical matrix that traps cellular debris within the tubular lumen. We classify these casts based on the specific cellular actors trapped within the protein matrix. The red blood cell cast is the definitive hallmark of glomerular hematuria, primarily signaling an active glomerulonephritis. White blood cell casts act as markers of interstitial inflammation, distinguishing acute pyelonephritis from a lower urinary tract infection. The muddy brown tubular epithelial cast is the most specific diagnostic indicator for acute tubular necrosis. Fatty casts indicate lipogyria, a feature classically associated with nephrotic syndrome or Fabry's disease. Casts function as pathological amber. They trap the specific actors of necrosis or inflammation at the site of injury, delivering a frozen snapshot of the distal nephron. Our focus now shifts to the biochemical fallout of the kidney, crystalluria and nephrolithiasis. The geometric diversity of urinary crystals reflects distinct metabolic failures. Calcium oxalate appears in 2 forms, the bipyramidal, envelope-shaped dihydrate, and the dumbbell-shaped monohydrate. Uric acid crystals are identified by their sharp, rhomboid structures. In patients with adult polycystic kidney disease, uric acid stones are the primary driver of nephrolithiasis. Struvite, or magnesium ammonium phosphate, presents a distinctive coffin lid appearance, driven by urease-producing bacterial infections. The flat hexagonal geometry of the cysteine crystal indicates a genetic amino acid transport defect. Calcium phosphate crystals take on a star-shaped geometry in alkaline urine. These correlate with incomplete distal renal tubular acidosis, which produces a characteristic paintbrush or bouquet of flowers appearance in the renal medulla on imaging. Crystal geometry acts as a metabolic fingerprint, identifying the specific biochemical failure or infectious agent driving stone formation. High-level clinical nephrology merges these microscopic observations with structural imaging and patient history. Medullary sponge kidney serves as a unifying clinical example, defined by a symptomatic triad of recurrent stones, UTIs, and hematuria. Recurrent UTIs map back to microscopic evidence of white blood cell casts and struvite crystals. Recurrent stones correlate to the presence of envelope-shaped calcium oxalate. Recurrent hematuria is classified by the shape of the red blood cells. By analyzing the shape of crystals, the cellular composition of casts, and red blood cell morphology, clinicians identify the specific pathophysiological mechanism and anatomical coordinate of renal disease.